Welcome to The Explainer. Today, we're jumping into something really critical for any trainee out there: how to manage patients with left ventricular assist devices, or LVADs. Let's dive right in. So, let's kick things off with a real mind bender. Your patient is awake, alert, talking to you, but you can't find a pulse. What do you do? Now, this isn't some medical mystery show. No, this is your first lesson in the world of continuous flow LVADs, where all the old rules, well, they kind of go out the window.
Okay, so where do we even start? We've got to go back to basics and completely rethink the physical exam. We're talking about a patient whose blood isn't just being pumped by their heart, but by a machine that runs nonstop. And this slide really lays it all out. Think about it. Your go-to assessment tools, feeling for a pulse, listening for a blood pressure, hearing those classic heart sounds, they're all different here. Instead of lub-dub, you're going to hear this constant mechanical hum. And because the blood is flowing continuously, that pulse you're trained to find, it's often just not there. So, if the old way doesn't work, how do you get a blood pressure? The answer is a Doppler. And honestly, this is a skill you just have to master. You'll put the cuff on, find the artery with the Doppler probe, and inflate until that whooshing sound disappears. Then, you slowly let the air out, and the moment you hear that sound come back, that's your reading. And here's the golden rule. You're aiming for a pressure between 70 to 80 millimeters of mercury. That's your sweet spot. Okay, here's a huge clinical pearl. Seriously, do not forget this. See that drive line? That's the cable that goes from the outside controller right through the skin to the pump inside. It is basically an open door for infection. So, every single time you see your patient, you have to inspect that exit site for any redness, swelling, or gunk. It's a big deal.
All right, so you've done your physical exam. What's next? Now it's time to talk to the machine itself. We're going to interrogate the device controller, which is basically the brain of the whole operation. This little box is going to give you a ton of data on exactly what the pump is doing.
And this is what you'll see. Think of these numbers as the pump's own set of vital signs. You've got flow, power, and pump speed. And here are the typical ranges for two of the most common LVADs you'll encounter. You really want to get familiar with these numbers, because if you see a value that's way outside this range, that's a huge red flag something's up.
All right, let's talk about a really key number you'll see on the controller, the pulsatility index, or PI. What the heck is that? In simple terms, it's a measure of how much the patient's own heart is still contributing. So, if the PI is high, it means their heart is giving a good squeeze and helping the pump out. But if the PI is low, that tells you the LVAD is doing pretty much all the heavy lifting.
And this is the takeaway right here. A low PI is a major alarm bell. It's telling you something is wrong. Usually it boils down to one of two problems. Either the patient is volume down, they're dry, and there isn't enough blood to fill the pump, or their own heart function has taken a nosedive. Either way, a low PI means you need to figure out why, and fast.
Okay, let's shift gears and talk about what is maybe the central challenge of managing any LVAD patient. It's this constant, nerve-wracking tightrope walk you have to do between two really bad outcomes: thrombosis and bleeding.
On one side of that tightrope, you've got clotting. We have to keep these patients on anticoagulants. Why? Because if a clot forms inside that pump, what we call pump thrombosis, it's an absolute disaster. We're talking device failure, stroke, it's a catastrophic event.
But then, on the other side of the tightrope, you've got this huge risk of bleeding. And it's a double whammy. First, you've got the anticoagulants we're giving them. Second, the pump itself causes a problem. The super-fast rotor can literally shred some of the body's natural clotting factors, leading to something called acquired von Willebrand syndrome. Put those two things together, and you have a patient who is incredibly prone to bleeding, especially GI bleeds.
So, keeping that constant tension in mind, let's dive into the specific complications. When things do go wrong, what are the big, scary things you need to be watching out for? And like we said, pump thrombosis has always been the big boogeyman of LVAD therapy. Especially with the older devices, like the HeartMate 2, it was a really serious problem that led to a lot of bad outcomes.
But then, technology got better, and this chart shows you just how much better. This is from the huge Momentum 3 trial. They compared the older HeartMate 2 to the newer HeartMate 3. Just look at the bar for the HeartMate 2. 70 confirmed pump thrombosis events. 70. Now look at the HeartMate 3 bar. 7. From 70 down to 7. That is an incredible 90% drop.
And it wasn't just a lucky break. It was a complete redesign of the pump, using magnetic levitation to make the rotor float, so it doesn't create as much damage to the blood. It was a total game changer.
So, for you on the friend lines, what does this mean? How do you catch this early? The key is looking for evidence of hemolysis. That's when red blood cells are getting chewed up as they go through a pump that's starting to clot. And your number one clue on a lab test? A rising LDH. If you see that lactate dehydrogenase level starting to creep up, alarm bells should be ringing in your head. You got to be thinking about pump thrombosis.
But even with better pumps, thrombosis isn't the only thing to worry about. You've got this whole checklist of potential problems. Bleeding, especially from the gut, is still a massive issue. We talked about driveline infections. Then there's right heart failure, stroke, both ischemic and hemorrhagic, and even aortic regurgitation that can develop down the road.
Okay, that was a lot of information, I know. So let's boil it all down. If you're going to remember just a few things from this, here's your LVAD pocket guide.
4 core principles. Number 1, your physical exam is totally different. Don't trust your fingers for a pulse, trust your Doppler for a BP. Number 2, get to know that controller. Know your normal numbers for flow, power, and speed. Number 3, watch that LDH like a hawk. It's your earliest warning sign for pump thrombosis. And finally, number 4, never ever forget that balancing act. Every single decision you make is a trade-off between clotting and bleeding.
And we'll leave you with this final thought. Look how much the technology has evolved just to tackle pump thrombosis. As these devices get better and old risks start to fade away, what are the new challenges that are going to emerge? It's a really interesting question, and it just shows that as clinicians, we've got to be ready to adapt.